The first attempt to define public health surveillance was John Grant. In those days, mortality data collection was simple but routine. Every night, towards 12 o'clock, a cart travels to different places with a lantern and a bellman. The bellman rings the bell and cries out, "Bring out your dead."
In his book, he emphasized the importance of reducing volumes of data to a few easy-to-understand tables, then interpret them, and prepare a few brief and precise paragraphs, so as to gain profit from the data analysis, in order to understand the increase and decrease of diseases.
John Grant emphasized the basic principles for data analysis and interpretation, although he failed to conceptualize the link of surveillance information to public health action. Since then, the definition of public health surveillance has evolved into different stages. In 1963, Alex Langmuir proposed the first standard definition of public health surveillance, and this is his definition.
Surveillance, when applied to a disease, means the continued watchfulness over the distribution and trends of incidence through the systematic collection, consolidation, and evaluation of morbidity and mortality reports and other relevant data. Intrinsic in the concept is the regular dissemination of the basic data and interpretations to all who have contributed and to all others who need to know.
The limitation of Dr. Langmuir's definition is that it did not elaborate who is directly responsible for disease control activities. In 1968, the 21st World Health Assembly adopted the concept of population surveillance, which was defined as
the systematic collection and use of epidemiologic information for the planning, implementation, and assessment of disease control.
The Assembly expanded Langmuir's definition to include the assumption that surveillance information is collected in order to take appropriate action to improve health outcomes. In other words, surveillance is information for action. The Assembly also affirmed the three main features of surveillance. First, the systematic collection of pertinent data. Second, the orderly consolidation and evaluation of this data. Third, the prompt dissemination of results to those who need to know, particularly those in position to take action. In 1986, the U.S. Center for Disease Control proposed another definition of surveillance. We will compare this definition with another definition proposed by Thacker and Berkelman in 1988. While the 1986 CDC definition uses the term epidemiologic surveillance, the 1988 Thacker and Berkelman definition introduces the new term public health surveillance. According to Thacker and Berkelman, the term epidemiologic surveillance focuses on using surveillance information for epidemiologic research, while public health surveillance focuses more on public health practice. They maintain that the use of the term epidemiologic surveillance is misleading because surveillance does not equal research. Most public health practitioners recognize the important interplay among epidemiologic studies, surveillance, and control activities. The components of the definition, like ongoing, systematic, collection, analysis, interpretation, and dissemination, have been consistent from the years
1662 to 2012.
However, some of the components of the definition have been changed. For example, the term epidemiologic surveillance was changed to public health surveillance, mortality data to health data, and disease control to public health practice or action. For purposes of this training, we will use the WHO definition for surveillance.
Public health surveillance is an ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice.
The word ongoing implies that data collection is continuous or constant as long as the threat of a particular health problem being monitored continue to exist. It also implies that one-time surveys or sporadic studies do not constitute surveillance. Systematic collection simply means the standard operating procedures or SOP adapted in collecting the data. The SOP should address the basic questions of what data to collect, why, where, when, and how.
Timeliness, simplicity, and completeness should be the basic principle that guide the development of SOP in data collection.
Let me emphasize that data collection should not overload the system. Otherwise, the system will become expensive to maintain and difficult to operate. This scenario will eventually lead to system failure.
Analysis and interpretation are the most critical components of surveillance because this is linked to decision making. Some surveillance systems are very good in collecting data, but analysis is either not done or inadequate.
If analysis is done, there is no interpretation. If interpretation is done, the interpretation is inaccurate. This scenario is often observed in local government units where surveillance systems are not supervised by adequately trained personnel. To prevent this risky scenario, public health surveillance systems should invest in employing competent epidemiologists and surveillance staff. Graduates of the field epidemiology training programs are specifically trained for this job. The phrase planning, implementation, and evaluation represents the core components in the management of public health programs or interventions. These components need timely and accurate information from surveillance systems to guide program managers and other agencies involved in disease prevention and control. The phrase public health practice means the development and application of preventive strategies and interventions in order to promote and protect the health of populations.
The use of this phrase, in surveillance definition, refers to the link of surveillance to other public health practitioners directly involved in the operations of disease prevention and control programs.
This phrase also emphasizes that the primary role of surveillance officers is to provide information and advice regarding control measures needed, but the decision and performance of the actual control operations must remain with the program managers and other designated health authorities. We have carefully dissected the components of the definition of public health surveillance. The goal of surveillance is not merely to collect data for analysis, but to guide public health policy and action. In fact, surveillance has been concisely defined as information for action. The objectives of surveillance systems will vary depending on the problem being addressed. It is very critical to have a clear objective at the beginning, because this will determine the type of data to be collected and the type of system to be established. For example, if the objective is early detection of polio outbreak, the data to be collected would be cases of acute flaccid paralysis, and the structure would be syndromic active surveillance system. Whereas, if the objective is to monitor the tuberculosis control program, the data to be collected would be program indicators, and the appropriate structure for this would be health information system. Therefore, different public health objectives require different surveillance systems. The World Bank described 6 categories of uses of public health surveillance. The first category is early warning. The system serves as an early warning to detect epidemics and identify public health emergencies. An example to this is the Philippine Integrated Disease Surveillance and Response. PIDs are monitors epidemic-prone diseases and those targeted for eradication and elimination. The second use of surveillance is impact assessment. An example to this is morbidity and mortality surveillance during disasters to assess its public health impact to affected communities. The third important use of surveillance is intervention development and implementation. For example, injury surveillance may show an increasing number of injuries due to motorcycle accidents. As a response, local government units may develop prevention and control program for motorcycle-related injuries and allocate resources. The fourth use of surveillance is intervention evaluation. For example, data on infant mortality rates are used to judge the effectiveness of infant survival programs such as oral rehydration solution, integrated management of childhood illnesses, vaccination, breastfeeding, and clean deliveries. The fifth use of surveillance is risk assessment. A good example to this is behavioral risk factor surveillance system. The system collects information on risk behaviors such as multiple sex partners, non-condom use, smoking, alcohol, and drug use. Finally, surveillance can be used in research. Surveillance data can be used in developing hypotheses that lead to analytic studies about risk factors for disease. For example, neonatal tetanus surveillance shows an increase of neonatal tetanus cases in a particular tribe.
Based on this information, a case control study can be done to identify risk factors for neonatal tetanus in this community.
Among the hypotheses to be tested in the study is the use of non-sterile cord-cutting instruments. We have discussed the definition, goal, objectives, and uses of public health surveillance.